Okay, welcome back. This will be your video lecture, chapter 36, musculoskeletal injuries. So let me introduce the chapter. Isolated musculoskeletal injuries are not life-threatening. Severe internal or external hemorrhage may occur, resulting in life-threatening conditions. Musculoskeletal injuries are part of the multi-system of trauma. Don't be distracted from the priorities of patient assessment and care by dramatic appearing musculoskeletal injuries. And we're going to talk about all of this. We're going to identify problems with airway, breathing, and circulation. We want to recognize life-threatening musculoskeletal injuries and MOI. Focus on immobilizing injuries, extremity or splinting, manage immediate life threats, package a patient for transport. Back pain is common, can lead to temporary, I almost don't want to even, that's correct. Yes, back pain is common, and no, very rarely does it lead to temporary or permanent disability. So let's look at the anatomy and physiology review. The musculoskeletal system, the function to provide shape to the body, to protect internal organs, to provide for the movement of the body, and the production of red blood cells. And this is the skeleton. I'll let you look at that. Skeletal muscles, they're voluntary movement attached to bones. The muscle contracts and pulls the attached bones together. Opposing muscles contract to move bones apart. We have ligaments and tendons. So ligaments, remember, are connective tissue that connect bone to bone, and tendons are connective tissue that connect muscle to bone. And so they give you an example here of a ligament attached to a bone. Here's your bone. There's the ligament. Ligament and bone. And then we have a tendon that is attached to muscle to bone. Cartilage is a connective tissue found between two bones. The function of cartilage is to provide that shock absorption. It allows bones to move against one another without friction and provides that support without a rigidity of the bone. 206 bones. That's what the number is that comprise the skeletal system. You have the axle, appendicular. The axial skeleton is the head's bones, the thorax is the spine. The appendicular skeleton is the pelvis, shoulder girdles, and the bones for the extremity. Bones are categorized by their shape, so long, short, flat, or sesamoid, like your kneecap. Living, metabolically active tissue with blood supply and nerves. That's good, and calcium and other minerals are deposited into bone and they're released to the blood as needed. Bone marrow in the cavity of certain bones produces blood cells. So all blood cells are produced in the bone marrow. This is the bones of the upper extremities, the bones of the lower extremities. You already know these. Joints, I'm not a big joint fan. I confused them in paramedic school all the time. It's just, I don't know if it's something I just don't want to learn, but either way, joints, say points at which bones meet and articulate to allow for motion. Types of movement, we have flexion, extension, adduction, abduction, circumduction, and rotation. The complex structure of bones, cartilage, and ligaments. So when we're looking at musculoskeletal injuries, we need to consider the injury or the chief complaint, a non-critical patient. We want to properly assess and manage that patient. The critical patient, look, we're going to get on the road. So no, we're not going to like try to put a hair traction splint on somebody with a broken femur if the MOI suggests that they could suffer other critical injuries, right? We're going to get that patient to the trauma center. We're going to focus our assessment using DCAP, BTLS, mnemonics. We're going to expose the injured area, and we're going to palpate and examine. Neurovascular status of injured extremities. So we want to assess that circulation. We want to check for sensation, and we want to assess motor functions in the upper extremities. Impaired distal neurovascular function due to musculoskeletal trauma is limb-threatening injury, and we're going to transport without delay. So we're going to get on the road as quick as possible if we discover that. We're going to splint some of these injuries in the position they're found. We will try to put that extremity back in a neutral position if possible. We're going to assess neurovascular status before and after splinting. That's super important to document that and reassess periodically through transport. Splinting and care of musculoskeletal injuries. The reason why we splint, right, is the mobilization to decrease injury and pain. We're going to elevate the injured extremity as long as doesn't compromise C-spine. We're going to apply a cold pack if we have them to the injured area. There's plenty of external devices that we have to stabilize injured extremities, but I think we have the cardboard splints that we use to prevent it from moving. And yeah, there are plenty of varieties of splints out there. So always treat your life-threatening conditions first. Nowhere in your primary assessment does it talk about splinting. Splinting is always done in the secondary survey. You want to assess the distal neurovascular status always before and after splinting, meaning check for a pulse, check for sensation. Pad splints as needed. Immobilize the injury to the bone to include the joint proximal to the injury and joint distal to the injury. I would remember that. It sounds like a test question. Immobilize the injury to joint to include bone proximal to the injury and bone distal to the injury. So rigid splints could be anything from wood to plastic to cardboard or metal that require padding. You're going to secure it in place with like a roller gauze. Do not secure so tightly that circulation is compromised. The moldable splints are very similar to that of board splints, except they're more pliable and can actually be molded to fit the extremity. Vacuum splints, I don't even know if we've ever carried them in the last 24 years of me working here, because undoubtedly they're going to get a hole in them. This is a example here of a vacuum splint. The sling and swath, it's a standalone splint for shoulder or clavicle injuries. The adjunct to supporting splint, the arm, elbow, forearm, or hand. The sling supports the arm by suspending it from the shoulder. The swath is a bandage or strap wrapped or tied around the patient's torso. I think here's an example of that. And that's the only good this triangular bandages do, really. The reason why if you ever see one, that's the reason why we have them. And they just go through some ways to apply them. I'm going to skip through this. All right, long backboard, patient handling device, and immobilize the extremity of the patient who's critical and must be transported without delay. The long backboard helps us to move the patient without complicating any extremity injuries that they may have. The traction splint, the good old traction splint. We use these for isolated Fractures to the midshaft of the femur. It helps to overcome spasms of the thigh muscles that accompany femur fractures. Here we have a traction splint. We've all at least put it on in EMT school at some point in time. It's a rectangular type traction splint. Has a steel stand or heel stand. Has that S hook on it right there. And that S hook is used, you know these. I'm not going to go through this. You know them. The traction splint restores thigh muscles to normal length. It decreases the volume of space available to collect blood from a large blood vessel. It aligns the ends of the femur to reduce the pain, which is one big reason why we use it. Uses the thigh muscle to provide stability. That frame fits against a fixed point of the skeleton, and the frame attaches a second point used to apply traction against a fixed point. There's the bipolar frame of the traction splint, meaning it has two poles, or two rails, is what I was trying to think of. And the unipolar traction splint is a device that only has one rail. Formable splints. They're malleable material that can be formed to the extremity. Improvised splint could be anything from a pillow to a cardboard box. Here's a towel that's been used as an improvised splint. So, fractures, the definition: any break in the bone that results from a variety of different forces. Direct, indirect, or twisting. Let's get the definitions of these. So, direct force being struck by a baseball bat in the upper arm, resulting in a fracture to the humerus. An indirect force would be falling on an outstretched hand, resulting in a fracture to the radius and ulna. Or twisting force, stepping in a hole while running, causing a twisting of the lower leg, resulting in a fracture to the tibia and fibula. Mechanisms: assaults, falls, gunshot wounds, motor vehicle crashes, and substantial forces. A pathologic fracture will be a bone break. It is weakened by disease, like somebody who has bone cancer. Different types of fractures. There's comminuted, impacted, the green stick, the oblique, spiral, and the transverse. And here are some examples of those. Here's a comminuted fracture, an impact fracture, green stick right there, oblique fracture, the spiral fracture, and a complete transverse fracture. Fractures can be classified as open or closed. If the bone breaks and causes a break to the integrity of the skin, it would be considered open. And the opposite of that would be a closed fracture. So, complications of these fractures: well, blood loss, lacerated blood vessels and nerves. Bleeding can be substantial and life-threatening. Fracture of a femur or pelvis, or multiple long bone fractures. So if you have bilateral femur fractures, that's quite a bit of blood loss. And we all know that a pelvis fracture can hold the entire blood volume of somebody. So pelvis fractures are extremely dangerous. Injuries to the nerves by broken bone ends may result in permanent loss of sensation, weakness, or even paralysis. Here's a sketch of an open fracture versus a closed fracture. The 5 P's of compartment syndrome. Well, there's pain, paresthesis, pallor, paralysis, pulselessness. How do we manage these long bone fractures? Well, we want to splint them, as long as if we have time to splint them. We always want to control the bleeding first place a dressing on any open wounds, and we never want to attempt to replace the broken bone ends back into the wound. And an example is splinting. So management of long bone fractures after immobilizing the extremity with a splint. Elevate as long as there's no C-spine problems with that. Cold pack if you have it. Reassess en route to the hospital. Humerus and forearms. Splinting with whatever you have. It could be any type of splint really. It could be moldable. Those cardboard splints work well. If it's femur, we want to use a traction splint if we're going to splint it. Excuse me. Lower leg. Again, any type of splint for those. A critical fracture. So let's look at that. What's considered a critical fracture? Well, femurs, pelvis, scapula, and the first rib, right? The amount of force it takes to break the first rib is a tremendous amount of force. That's why it's critical fracture. The scapula and the first rib, that's what it says. Just what I said. Force required to break these bones can result in injuries intrathoracic organs. A broken clavicle can result in a pneumothorax or laceration of a large blood vessel. And then a pelvic fracture, it can result up to 2,000 milliliters of blood loss, quite a bit of blood loss. I haven't seen these in years. We carried these back in the late 80s to early 90s. And these are called mass trousers. The goal of these really, when they first came out, was these are inflatable and it would force blood up from the lower extremities. It would be a way to shunt blood artificially, shunt it to the upper extremities and thorax. Problem with that was when you took them off, the blood loss just, was tremendous. So they just were not scientifically proven to work. But what they made was for a great thing to stabilize a pelvis. If you had a pelvis fracture, they were the best. And then image B here is what they call a pelvic girdle. And those are, we've talked about getting them here and to help stabilize pelvis fractures. So we want you to stabilize it the best you can. In today's setting, we would ask you to get a sheet and just to tie the sheet to bind the pelvis that way. That was a pelvic binder, by the way, that I just showed here. It's called a pelvic binder. Single fracture femur can result in 1,500 milliliters of blood loss. And so bilateral femur fractures can result up to 50% of the blood volume. And that's why we have the traction splint. But again, we're not going to use this unless it's an isolated fracture of the femur. All right. If you have MOIs that suggest that the patient could be in bad shape, then we need to get on the road. So you cannot use the traction splint if the injury is within 2 inches from the knee or hip. If the hip or pelvic injury is suspected, or injuries to the knee, ankle, lower leg. And they're going to go through here putting this unipolar traction splint on. And now they're going to show how to put a bipolar traction splint on. For joint injuries, a sprain is considered a joint force beyond normal range of motion, stretching or tearing of the ligaments around the joint. And then an avulsion fracture is a ligament that tears away a piece of bone as it is stretched or torn. Dislocation is a complete displacement of a joint, produces obvious deformity to the affected joint. And a subluxation is a partial displacement of a joint. Here you can see we have a kneecap that is dislocated, and that's the x-ray of that. So when you're splinting a joint, basically you want to try to first to put it in a neutral position. Good luck. A lot of them don't go into a neutral position, so you're just going to splint it as you find it. Always check for CNS. That's where these vacuum splints, where they are beneficial because of what you can do there. Hip fractures or dislocations involve the proximal femur. Hip dislocations, the head of the femur displaced to the front or back of the pelvis, occurs from falls or forcing the joint beyond normal range of motion. Hip injuries are painful, and we want you to use the scoop stretcher if possible. When we talk about strains, again, muscle fibers are stretched beyond their limitations, and they result in tearing of the fibers. Muscles are under extreme stress, lifting heavy weights. And that is it for this chapter. All right. See you in class.